Good afternoon, everyone. I'd like to thank everyone for joining us today at our VDH Department of Health Project Echo COVID-19 Telehealth Clinic. Quick disclaimers. VDH is rapidly working to develop resources to address COVID-19. Guidance does change, and all participants are encouraged to continue their own research. If you have a question, please enter it into the chat function, and we will include a response in an agency follow-up correspondence. Next slide, please. This session does count toward continuing education credits. VNA has improved 1 hour CNE, and Carilions Clinic CME program designates this live as 1 AMA PRA Category 1 credit. All speakers have no conflict of interest to disclose, and following the session, you will be emailed a didactic evaluation link and instruction for receiving educational credit. Next slide, please. Some helpful hints. This Echo Clinic didactic is used for educational purposes. By participating, you are consenting to being recorded. Recordings will be on the projectechobox.com, password protected. Clinicians unable to join the live can view the recording later, and materials will be shared with our Project Echo community. Please mute yourself when not speaking, use the chat function to ask questions, and please do not share information that identifies or can be linked to a patient's identity. Closed captioning is also offered for this session. Visit the link in the chat box to connect to Virginia Relay, and then enable your device. Once you do this, a button will say closed captioning, and at that time, hit the link to connect. Next slide, please. Our facilitator today is Dr. Stephanie Greasy-Williams. Dr. Greasy-Williams is a board-certified pediatrician with experience in both emergency rooms and urgent care, as well as 6 years at the CDC Center for Preparedness and Response. Dr. Greasy-Williams is currently working diligently with VDH to help our COVID-19 response. Our VDH consultants are Diane Woolard and Carol Jamerson. Diane Woolard is the former director of VDH's Division of Surveillance and Investigation, who came out of retirement to help VDH on the COVID-19 response. Carol Jamerson is a nurse epidemiologist with VDH's Healthcare Associated Infections and Antimicrobial Resistance Program, and is an infection preventionist with 25 years experience and board certification in infection prevention and control. Our clinical consultant is Dr. Colin Rosencraft, trained in internal medicine palliative in Richmond, Virginia, before practicing and teaching nationally and internationally, focused on implementing palliative medicine in developing regions. He now lives again in Richmond and has retired from clinical practice, but continues an interest in medical education, ethics, and economics. Our speaker today is Dr. Kathy Wibberley. Dr. Wibberley is the Director of Research at the Karen S. Rubins Center for Telehealth, University of Virginia School of Medicine, Charlottesville, Virginia. Her primary responsibilities in this position are consulting and the development of telehealth infrastructure, clinical applications, and rural health. Dr. Wibberley is also the director of the Mid-Atlantic Telehealth Resource Center, the Karen S. Rubins Center for Telehealth, University of Virginia School of Medicine, where she works to establish the center, designing, implementing, and evaluating programs, as well as helping expand, with our partners, the reach of telehealth capabilities throughout the Commonwealth and neighboring states. She additionally is appointed as the Assistant Professor of Public Health Sciences at the UVA School of Medicine and faculty at the Health Appalachia Institute of UVA College School of Wise as an adjunct faculty at L. Douglas School, Wilder School for Government and Public Affairs at VCU. With that, I'd like to turn this over to Dr. Greasy-Williams.
Thank you, Hector, and good afternoon, everyone. I'll start by briefly reviewing Virginia's case counts and our epidemic curve. Of note, the information on both of these slides is available on the Virginia Department of Health COVID homepage. As of yesterday, Virginia has 46,905 total cases with 1,428 deaths. As you can see on the heat map when it returns, Northern Virginia, the Richmond metro area, and Southeastern Virginia account for the highest numbers of total cases. Next slide, please. Thank you. On our epidemic curve, it reveals the number of cases by date of symptom onset, with the yellow line representing a 7-day moving average. As you can see, it seems that cases have stabilized, if not decreased a bit. However, it's important to note that in the illness occurring in the past 14 days may not have been reported yet. This means that we'll need to wait another week or two before we can truly say or reliably say that the case numbers are decreasing. Next slide, please. Today's clinic topic will be telehealth. This is an area of very rapid growth given the start of this pandemic. And today there will be no case presentation, and that's to allow time for a robust question and answer session after Dr. Wibberley's presentation. We anticipate that you will have a lot of questions for her. Next slide, please. So without further ado, I'd like to welcome Dr. Wibberley from the Mid-Atlantic Telehealth Resource Center. And Nick, I'm going to ask that you switch over to her set of slides if possible. Perfect. And Dr. Wibberley, please go ahead.
Great, thank you. Let's go ahead and hit to the next slide. So what I want to do is just do a really quick overview of some of the things that you really need to know and best practices regarding telehealth, because I know everyone is transitioning quickly to this. And so first things first is just to level the playing field as to our understanding of what this is and what it isn't. Um, Telehealth is simply a technology, and it should be seen as just a tool in a clinician's toolbox. So it's not a separate service. So you're not providing a service and then you're providing a telehealth service. You're providing a healthcare service and you're using telehealth as a tool. So I just wanted to make sure that that was known. All right, next slide. So one of the things that I am very adamant about, and I think we all should be, is that telehealth should not change the standard of care. So and standard of care as defined from a malpractice or legal standpoint is the type and level of care an ordinary prudent healthcare professional with the same training and experience would provide under similar circumstances in the same community. What does that really mean? Um, Essentially, good medicine is good medicine, bad medicine is bad medicine. And if the majority of your peers think that what you're doing in terms of diagnostics or assessment does not meet the standard of care, and that, if the relevant or the available information does not lend to the ability to diagnose or assess a particular condition, you shouldn't be doing it. And so again, a lot of this is going to be on your clinical judgment, but that's what you're trained for, right, as clinicians. And so if you feel like, I'm not getting enough data, I'm not getting enough information, I don't have enough history or background, or my visual image is not clear enough to make any kind of assessment because, the bandwidth is bad or the audio connection is bad, please don't feel compelled to make an assessment. There are definitely opportunities for you to say, you need to come into the office, or you need to go to an urgent care center, or you actually need to go to the emergency room. We can't do what we need to do here. So I just want to make sure that people feel free and understand that. With that said, there's a lot more that you can do with telehealth than most people realize. And so next slide. I think the reason that the majority of us are even on this Project Echo is because of COVID-19 and the impact that it has had on practice, on people's fear of exposure, on clinicians' fear of exposure. And so, this slide is very telling. I mean, who led the digital transformation of your company? It was COVID-19. There have been just thousands of people contacting me in the last 3 months saying, we might have been thinking about telehealth, but we weren't really serious about it, but now we need to start yesterday. And that's really the case for the majority of healthcare providers right now. And so I want to say that I am just thrilled that we have a good 20 years of experience and best practices, even though telehealth is quote unquote an overnight success. So next slide. As you all know, what it took to make telehealth an overnight success was the elimination of a lot of the policy-related barriers. And I'm not going to go through them all. I think you're very well aware now of, the reimbursement was a major one, and the flexibility now with reimbursement, and even things like licensing and credentialing and HIPAA and just all of that. But with that, I think, is what happens on the next slide, which is I think we have the potential for having very sloppy telemedicine practices. And so what I want to do is try to at least lift or raise the bar just a little bit with what I'm going to share with you in terms of, let's not get ourselves in a position where when the pandemic ends, we have to go back and fix a lot of stuff. So next slide. So for those of you who are just starting out, I know you had to ramp up quickly. I know you had to pivot quickly. I know that you didn't have months and months of prep time to develop these things. But now that you are in it, it does you well to even go backwards a little bit and start developing some policies and procedures and protocols around your use of telehealth. This is going to be important for you going forward, and so I'm going to kind of just walk through a few key things that you really need to think about. So what a policy is basically defining your practice's position on what you plan to do and why you plan to do it. So it's generally pretty brief. Some examples of things to think about. Now, is your policy to only address patients suspected or diagnosed with COVID-19 as a way to minimize exposure, or is it going to be for all patients? Um, is your policy to temporarily address urgent care needs with telehealth and to delay non-urgent care visits in response to COVID-19? Is that really what your plan is? Or is your policy to develop a comprehensive strategy for addressing all your patients' needs as appropriate, and that you're going to continue using telehealth technologies beyond COVID-19, because that's going to have a very different implication for what you do and the procedures that you develop and what you focus on. So I think it really helps for any of you, whether you're in private practice or in a large organization, to really think about, what is my reason for using telehealth? And what we've heard is, some of you started out thinking, oh, this is just going to be temporary to address some urgent care needs for patients who can't delay care. And then now you're thinking, well, this is kind of cool. I like this. I think I want to integrate this. And that's great. You can pivot, but then be kind of transparent about this is what we're going to do. This is where we started, but this is our new policy. And let's start thinking about procedures and protocols related to the new policy. So next slide. So procedures really describe how a policy will be put into action or operationalized. And one of the things that I want to emphasize in terms of a best practice is don't work in silos when you're developing procedures. Include everyone it may impact in the planning, from your front desk person to your billing team, to every clinician, to your IT folks, to your housekeeping staff. And I'll get back to that in a second. But oftentimes people sit down and write policies and procedures, and that you task that to someone. All right, so you're the administrator, sit down and write down our procedures for this. And what they write down may not work very well for everyone, and it creates glitches. If you want things to work smoothly, you really should sit down and talk through this with everyone involved. So a key example might be, well, why would I involve my housekeeping staff? Well, they're the ones who clean your office in the evening, and they may see that your camera is, misaligned and move it or unplug it because they need to dust something. And then you come into the office expecting everything to be working. You turn on your monitor, you have a patient in 30 seconds, and you turn it on and nothing's working. So that's the communication that needs to happen with everyone. The person who answers the phone, they're the ones who are going to need to explain to your patient or to a client, you know, how do we access telehealth? And so those are things that we need to think about. So next slide. So procedures also define roles and responsibilities regarding things like who's going to do what forms will be used, what will need to be documented, and limits to professional discretion. And those are things we need to think through. And so, take a step back and think through these, even though most of you have already started. And think about both the patient experience and the provider experience as you're developing your procedures. And it's always a good practice to have someone play the role of the patient as you're developing your procedures, because you definitely want the patient to have a good experience. So here are some very pragmatic things to think through. So next slide. Um, how will my patient be informed about the availability of telehealth services? So who's going to tell them? Is it going to be the clinician? Is it going to be the person who answers the phone? What will they be told? How will they be told? And when will they be told? So those are all things that you need to really think through in terms of your policies and your, particularly your procedures. Next slide. How will telehealth visits be scheduled, and who will do the scheduling? So oftentimes clinicians have preferences. Some will say, I only want to have certain blocks of time where I do telehealth visits. And so Mondays, from 4 o'clock to 6 o'clock is my telehealth block and schedule telehealth visits then. Others will say schedule just like any office visit. I'm going to go in clinic room 1 at 10 o'clock and I'm going to see a patient, and then I'm going to go back to my office at 10:15 and I'm going to turn on the video and see my patient by telehealth, and then I'll go over to clinic room 3. Um, and some people are going to say, I'm always available. If there is a patient that calls and let's say they want to cancel an appointment because they're afraid of exposure, um, I want you to immediately offer them a telehealth visit. Okay, so always available. This is going to be very different in how you develop your procedures and your policies. And it's also going to differ from provider to provider. So you really need to talk through what the preference is and how you're going to be scheduling. And you may at some point try some things out and go, this is not working. Let's flip this and change our technique. But all of this needs to be figured out, talked through, piloted, and then communicated with your patients so that they know. Next slide. So this is one part that oftentimes we forget. How will the patient be prepared and who will prepare the patient? So a clinician needs to really think through, what information do I need before a visit? Is that information need going to be different for a new patient versus an established patient? Is there paperwork that needs to be filled out? Who's going to do the consent forms, or will there be consent forms? Who's going to gather this information and how? Most clinicians don't want to get on a screen with a patient and then all of a sudden realize they have no history, no background. They're getting things on the fly from the patient. But you also need to think about, like, who's going to send the patient a reminder. If it's a scheduled visit, oftentimes if it's an office visit, you have a text message or you have a phone call to a patient the day before or 2 days before. Is that same process going to be in place for a telehealth visit? And who's going to be in charge of that? So really think that through from a workflow perspective. All right, next slide. Think about where the provider will be during the telehealth visit. So oftentimes the provider will come into the office, but oftentimes, just as often, they're going to be at home, in a home office, or some other location. So that provider really needs to think about, is the location private and secure? And if it's not, how do you make it so? A lot of you are working in a home office right now with kids at home because kids are not at school, and with pets at home, and with other family members at home. Do you have a sign on the door that you can put to notify people, please don't come in, I'm actually in a visit? Because if they walk in your room during a patient visit, that's actually a HIPAA violation. So you really need to think that through. How will you as a provider know when the patient's ready to be seen? Is there going to be kind of a virtual waiting room where you have an email notification or some kind of notification saying, hey, somebody's in your waiting room? What will the patient see or hear when they're in the waiting room? It's a great, when they're in your office waiting room, there's oftentimes literature, there's oftentimes things for them to do, there's often even just signage. Will you provide that in your virtual waiting room so that your patient, that's a great place for patient education. How will you interface with your EMR? So a lot of times a provider will go, okay, I'm going to do a telehealth visit, pull up their telephone, pull up their tablet, do the video visit, and realize that you can't view two screens on your tablet, you can't pull up the EMR information side by side. And so those are things you really should think through in advance. Sometimes people use dual monitors just for that purpose. Sometimes you might do the visit on your tablet and have your laptop for your EMR, or vice versa, if you can access your EMR via your tablet. So really be thinking about kind of that setup. And then another thing to really think about is, what happens if someone's running late? So who's going to notify whom, and how do you notify? So if you have a patient sitting in the quote unquote waiting room and you're running late, and of course that never happens to a clinician, right? How are you going to notify that patient that's just sitting in that waiting room wondering, like, what happened? Is the technology working? Are you showing up? So think through that, but also think about some of the key things that you need to ask the patient when they come on the screen. One of the key questions is, where are you right now? Don't assume that the patient's at home. We've had patients sitting in cars. And right now during COVID, there's a lot of latitude over that, but They may be sitting in cars with other family members. You're going to need to document that there are other people and make sure that the patient gives you consent that other people are listening into this conversation. But we also had a question, what happens if the patient's in the car and driving over state lines because they just said they were on their way to visit uh, their, son or a daughter who's in North Carolina, and here you are in Virginia. You now have licensing issues because that patient is about to cross state lines. Right now you might not, but later you will. So there are things that you really need to start asking yourself. So where are you, but also where is the patient? All right, next slide. Things to also think through before the visit are what happens at the end of the visit. So do you just hang up? Will there be some kind of follow-up? Will it be by telehealth? How are you going to coordinate that? Who coordinates that follow-up? How will you document the visit? And who's going to document? And how will the visit be billed? So that's where your billing people need to come in. What information do they need for you to document so they know how to appropriately bill for that? Was it a phone call? Was it a video visit? How long was the visit? All of those things need to be thought through. All right, next slide. So what is a protocol? A protocol just takes it to the next level in terms of defining the particular set of operating procedures, and sometimes it's accompanied by a workflow diagram. And this little graphic says, telemedicine success linked to workflow rather than technology, and I would say that is absolutely true. People who hate telemedicine are often the people who hate it because the workflow doesn't work for them. It's so complicated or it's so different than what their normal in-person visit is that they go, I can't make this work because I have to think so differently about a telehealth visit. You don't really have to, but you need to design your workflow in a way that works for you. And so really think about that. And the agreement between parties is, it could be an agreement between you and the patient, so the patient knows what to expect, but it could be you're doing a visit with another provider because it's a consult, or you're doing a hub and spoke model. So let's say you're a specialist consulting with someone at an FQHC who has a patient. And so all of those things really need to kind of be developed and thought through. So next slide. Some things in terms of thinking about workflow are you really should have a clinical protocol for at least these visit types if you're a primary care provider. If you're a specialty provider, that's a little bit of a different story and we can work through that, but I can't go through all of those. But you really should have a clinical protocol for what you're going to do if you're doing an acute care on-demand visit, if you're deciding to do those. You should have a clinical protocol for scheduled follow-up visits, and you should have one for scheduled wellness visits. And I'm talking more on, for those of you who are on the um, medical side of things. If you are a behavioral health person, you can really kind of tweak that to, you can have on-demand urgent care visits as well as, follow-up counseling sessions with patients, or just a check-in. This is just a monthly check-in. Things seem to be doing well. I just want to check up and make sure things continue to go well. You should have that protocol. So what needs to be in that protocol? Here are some tips. If you've not been doing telehealth at all and you're just getting started, you might want to take a look at your records and see what are the most frequently seen conditions and their corresponding ICD or ACPS codes. And then identify what you would do to assess those patients if they were physically in your office. And then highlight those things that are must-haves versus to meet the standard of care. I know this is going to take a little time, but it helps you in the long run to do this. Identify what documentation is required for that condition or ICD code, what you would identify when you would treat and when you would need to refer, and then when you would or wouldn't be able to prescribe if needed. Again, think about COVID-19, but also think about beyond COVID-19 if your policy is, we're going to do this beyond COVID-19. All right, next slide. So a workflow is basically the sequence of physical and cognitive tasks performed between you and whoever else is involved in this workflow. And so, the picture I have before you is kind of the typical, like, how do you get the fox and the chicken and the, the grain from one side to the other? And really that's how you want to think through your telehealth visit. If I want to do a telehealth visit I want to be able to bill for it. I want my patient to show up. I need this information before I see the patient. I need these forms filled out. How are they going to fill it out? Who's going to do that? And basically outlining all of that. And so the next slide basically shows what is often seen in a workflow diagram. So if we can hit that next slide. And you don't have to do it in nice graphic pictures, but this is one way people do it, is to actually develop a workflow diagram. So this is what happens. This is who's in charge. We're going to color code it. Or some people who don't like the pictures and the graphs and the things will just do it in a document that says the day before the patient's appointment, who's going to identify the patient, who's going to call them, who's going to remind them of the visit, how are we going to tell the patient how to access the telehealth portal, who is going to, all those things, just outline them, write them down so that you can change them if something doesn't work well. One of the main things that people run into is, they don't like the way something's going, so they tweak it, but then they don't tell anyone else they've tweaked their policies or procedures, and so the rest of their staff don't know, and you run into a lot of communication problems that way. So, document what you can. So next slide. So this is about actually seeing the patient or client. And you as a clinician, if I'm assuming I'm talking to a lot of clinicians right now because this is Project Echo, you need to ask yourself, how do I look and sound professional? So again, this goes back to the let's fix sloppy. Um, have I tested the audio and video before the visit? How's my lighting look? If you're sitting in front of a window that's backlit, you may look completely ghosted and washed out to your patient. They're not going to be able to see your eyes. They're not, you're just going to appear as this ghosted image. That's not going to look very professional. So you really should think about your lighting before a visit. Um, Particularly important if you don't have a kind of home office setup or office setup and you're just grabbing a visit on your tablet wherever you happen to be. Really think about lighting. What am I wearing? What's in my background? How do I introduce myself? How do I verify my identity? So oftentimes in an office, you don't think about that because you think, well, this is my office. I've got my shingle up. My diplomas are on the wall. It's obvious this is an office. This is a professional organization. But think about this from a patient's perspective. They're connecting to someone, and if they are not your usual patient, let's say this is someone who's never seen you before, what's their first impression of you? How do they even know that you're a legitimate provider? Think about what you might want to share with them to verify your identity and to really give them some comfort that you truly are, a doctor or a nurse practitioner or a PA or, whatever you happen to be. Um, how will I ask about verifying location of the patient, and what happens if something goes wrong? What happens if there's a storm out there and the power goes out and your router goes down and you lose your internet connection? Who's going to contact who, and do you have a cell phone number for that patient? And have you communicated with the patients and procedures? If we lose our connection, I'm going to call you, or if we lose our connection, I want you to call me. Those are things that you really want to think through and communicate with your patient, hopefully prior to your visit. All right, next slide. We have whole etiquette checklists, and so I always recommend if this is your kind of first foray into telehealth, there are printable checklists. You can just print one out, stick it on the wall next to your computer. So think about the privacy, think about the appropriate location, avoid background noise, think about lighting. Do you have the internet going? Is it sometimes you might want to test your upload and download speed before a visit, especially if you're walking around the house, because different parts of the house have, if you're on Wi-Fi, may have very different connectivity issues. Um, so those are all things that you can really think about. Next slide. So the thing that a lot of people ask about is, how do I even assess a patient? Let's say, I don't have peripheral devices, my patient doesn't have peripheral devices. How do I even do a physical exam? And so I think the key word is that it's going to be a provider-directed physical exam, meaning you're going to need to teach your patient how to be your hands. You have the eyes and the ears if you have video. If you're only on the phone, you're only going to have the audio. So you're going to need to really teach yourself how to teach. Um, So think about, instructing a child in some ways on how to, let's say, take their temperature or feel for a lump, or um, and start thinking about the language that you would use for that. So let's say you do have visual, and with the video, you can ask people, to get closer to the camera. You're going to need to instruct your patient because they may be standing at a very strange angle from their camera. They may be just holding their cell phone, and it could be blurry because it's not focusing because they're moving. So you're going to have to say, could you hold your camera still for a moment so it focuses on your eye? Can you bring it a little bit closer? You know what, your finger is blocking the camera a little bit, so it's fuzzy. Can you move your finger to the right? Those are all kind of communication skills that will help you with your visit. Um, you can very easily have them open your eyes, wider. Look, you can look at their pupils. You can check for light reactivity with your camera. You can have the patient look up and down and left and right. So those are things that you would do in your office, but have that camera image. You can absolutely have them open their mouth, stick out their tongue, say ah into the camera. Um, if you can't see well, don't stop there. You can say, could you go get a flashlight or turn on your camera, your cell phone flashlight so that it's better lit. So those are all things that you really need to kind of be thinking about. Um, if you obviously can't touch a patient, you can show them how to evaluate their sinuses by demonstrating to them where to feel on their hands. You can have them feel for lymph nodes and show them where to tap. You can ask them to describe pain or tenderness. So those are all things that you can do with your patient. And so don't think that just because you can't be there, you can't do any kind of physical exam. So the next slide. It's also okay to use consumer devices where they're available. So they may not have a professional grade thermometer. You may not even in your office. They may not have the scale. But you absolutely can say, hey, can you go get your thermometer if they have one? A lot of people do, and take your temperature and have them. And for some patients, you may actually have to guide them and teach them how to take their temperature correctly. A lot of patients don't do that. If they have a scale at home, so if you're doing a wellness visit and you want their weight, you can say, hey, can you go get your scale and stand on it? And let's take a look. You might have to show them, if they have a mechanical scale, how to zero it and calibrate their scale. But if they're a digital scale, you can just, show me the weight. If you're holding your phone, hey, show me the weight when you get the weight. Um, Blood pressure cuff, again, some patients do have that. Some people, if they're diabetic, will have a glucometer. They can show you their readings. Um, you can, for blood pressure, most people don't take their blood pressure correctly, so you may have to observe them taking it and, teach them the guidelines. Put your feet down on the floor, use, all those things. But so anticipate needing to take a little bit more time than you would in an office visit, because you're going to need to, one, improve your communication skills to teach your patient how to do these things, but you're also going to need to allow some time for the patient to get some of the devices that they might have at home to get some of those readings. And what you'll want to document is a patient used their home scale, right? So that we know that they weren't in an office scale. A lot of patients have Fitbits, so you can actually get a resting heart rate reading. You can get their actual heart rate reading, but you can also teach teach patient how to take their pulse. So teach them where to put their fingers, and you can actually time it, and they can just count out loud if you're not sure they're doing it right. Each time they hear a beat, and then you tell them when to stop, and now you have heart rate reading. So these are all things that, if you don't have peripheral devices, you can do, and there are peripheral devices around. So if you have time in the next year to really think about, I'm going to be doing these visits and I want to have access to peripheral devices for my patients, you can really think about, I can have a whole set in my office and clean them, and then how do I get them to my patients? Or are there a subset of patients that I want them to have? I want every one of my patients who are hypertensive to have a blood pressure cuff at home. And so, how am I going to make sure that that happens? All right, next slide. That's kind of my big picture as to some of the key things that I want people to know about telehealth. And so just real quickly, we are telehealth resource centers. We are federally funded, and our whole role is to provide technical assistance, and we're your free consultants. So the next slide. We serve the whole country, and I serve a 9-state region, Virginia being one of them. So this is my website, matrc.org. We're Mid-Atlantic Telehealth Resource Center. And right on that homepage is that COVID-19 toolkit. You see the picture of the virus. So if you click on that, you'll get what's on the next slide, which is our toolkit that we've developed for COVID-19. So all of the things that I shared with you are actually on the toolkit, but with greater depth. So like performing a physical exam, we have curated great videos on how do you perform a physical exam. And there's a whole set of videos on everything from a skin exam to a musculoskeletal exam. All of those things are on there. And we invite you to kind of visit that. And just real quickly, the next couple slides, and you can just flip through those one after another, just gives you an idea of our services, and they're all free of charge. We have virtual office hours, we have consultants who can work with you, we have web-based toolkits, we do offer a conference. And so if you're ever in need of understanding or information about this, just visit our website and it'll show you how to contact me or contact our team. We do have a regional page. So Virginia page gives you like Virginia guidelines, regulations, licensing requirements, and we have COVID-19 specific ones as well. And so the next slide just gives my contact information, and I think I'm supposed to leave the rest of the time for Q&A.